Hello, Miss Young. I see we are here to talk about your results today.
Yes. I have a bunch of questions.
Well, Dr. Young will be in shortly to answer them.
Okay.
Good morning, Miss Young. How are you?
I'm good.
It's good. I saw that you have already visited with Nurse Young, and she told you that your test results have came in. So, from your colonoscopy, biopsy, and your DNA stool test, it has confirmed that your cancer has come back.
How does the DNA stool test confirm that my cancer has come back?
With the DNA stool test, since you were having blood in your stool, I thought it was good to take it. And what we do is we put it in a special container on a small card, and we send it to the laboratory, and they do extra testing to confirm that the cancer is indeed back.
Okay, so chemotherapy again?
I do not recommend chemotherapy right now because it has metastasized to your lower anterior colon. What I'm going to explain to you is that I have a few diagrams, just if you had any questions. So we have right now, here's a diagram. We have your let me just draw over here so you can see. We have your esophagus. This is your stomach. Right here we have your colon, aka your large intestine. Inside here, we have our small intestine. And down here, we have our rectum and your anus. And so after your food has been chewed and swallowed, it's going to move through your esophagus, which is also, it's just a long muscular tube that serves as a passageway for food just to travel through to your mouth, to your stomach. Once it enters your stomach, it mixes with stomach acids, and these acids begin to digest and break down. When the food leaves your stomach, it's going to enter your small intestine. There, it's going to continue to digest. Okay, now with your problem right now, we have. I'm going to draw a little bit more of your anatomy. We have your splenic flexure. And this right here is your descending colon. And right here is your sigmoid colon. Now, from the looks of it, of our colonoscopy, it looks like the cancer has only damaged this part of your descending colon. And in my advice, we are going to have to do a low anterior resection. So, if we proceed with the surgery, which I highly recommend, so the cancer is not metastasized anymore, you can see it's at the lower of your descending colon and your sigmoid colon. What I plan to do with my team of surgeons, highly professionals, is you can see the anatomy again. You'll still have your large intestine, small intestine. What we're going to mainly focus on is cutting out this part of your sigmoid colon, and we are going to bring because this all right here is dead. It's metastasized. We need to get this cancer out. So we're going to bring this part of your descending colon, and I'm going to reattach it to your rectum so you can have better movements and hopefully stop the spread of this metastatic cancer.
This is Dr. Young here, and I am here with Miss Young, my patient. And what have we decided to do today? Surgery! Yes. So a week from now, she's going to have surgery. She's going to be off all of her anti-inflammatory medicines, any kind of blood thinners. She's not going to take any aspirin no matter how bad her head hurts. I'm going to give her some bicycle tablets. She's going to take 2 of those daily, starting in the morning and then 2 at night. Before her surgery, she is going to take the Marilax mixture. She will be cleaned out before her surgery, and we are going to get this cancer. Also, she is not going to eat prior to surgery, at least 24 hours the night before, okay? She will be all cleaned out. No pancakes, no waffles, no bacon. I will be enjoying bacon and waffles, but you cannot. Deal? Deal. Also, on another note, there are about 600,000 of these procedures done yearly, not only for cancer, but any kind of other bowel obstructions. There is robotic, minimally invasive, and open. You really want to try to avoid open at all possible, but Miss Young has requested that we do it open for her at this time. She does not want to waste time with the laparoscopic. So, we are here in the operating room, and Miss Young is already on the bed. I will go over how we are going to position her and a little bit more about her surgery, just so she's clear, even though she has already consented for this, and I just want to go over a little bit more. Hello, Miss Young. Please lay down on the operating bed. Alright, don't move because it is very small space. We have our anesthesia and all of our other care providers here. Now, how you're going to be positioned is you're going to be supine. Now I'm going to tuck your little arms to the side of your body with this sheet, okay? And what we are going to do is we are going to make a midline incision about that big, and our team will do the rest. Alright, are you ready to do this? Yay! Let's do it.
For my first assistant, can I get a drum roll, please? It's going to be Nurse Kaylee. And my assistant will be the lovely Miss Assistant Young. Woohoo! And guys, the most important person that has taught me everything I know about surgery, the Dr. Young. All right, team. Y'all ready to do this?
Woo!
All right. We have Nurse Young, Dr. Young, and my assistant Young. And I'm Dr. Young. Let's get this done. I'm going to make an incision. Can I please have the knife? Thank you. You're going to make an incision. You're going to put this back over there. So now we are looking. I'm going to need a bovie. Oh yeah, thank you. We're going to stop all our bleeding. Okay. Can you help me retract in here? Oh yeah, just get in there, right there. We're about 3 hours into this surgery. I have now located on our descending colon, our sigmoid, where I can see the cancer. Do you guys see this?
Yeah.
Needs to go. All right, now I'm going to need stapler. Thank you. All right. We're going to staple off. Can you reload that, please? Thank you. We're going to staple off. Now, we have our dead part of our bowel, our cancerous bowel, and I'm going to put that in a little sterile bucket. And now I'm going to need anastomosis up in here. Now we're going to run it and make sure nothing else is occluded. Oh yeah, see, this looks like very nice, very nice, very, very good. Miss Young should be very happy, and hopefully we've got all the cancer. All right, let's close them up. I am headed to post-op to see my patient after that wonderful surgery. How could it not be wonderful with that amazing staff of Youngs? But here we are. Hello, Miss Young. How are you doing?
Good.
Good. I see that the anesthesia is just now wearing off. You may feel some abdominal pain, especially since you went through an open procedure. We are going to give you meds through intravenous. We'll continue to give you antibiotics post-operatively. Nothing may be taken by mouth until certain that you have normal colon function is resumed. Is that understood? Very, very good. We will be listening to your abdomen with a stethoscope to hear bowel sounds, as when you pass gas. Make sure everything is sounding great.
So the day after surgery, I will let the nurses know I want you to get out of bed and move around. It's important to get up as soon as possible because physical activity stimulates the bowel function. It helps blood circulation return to normal. Does that everything make sense, Miss Young? Mm-hmm. All right. Well, if you need anything, you let our staff know and we will get straight to it.
Oh, is that so?
Very so.
Okay.
Goodbye, Miss Young.